Good day to all of you. Today I'm going to talk about sensory ascending pathways, which is a very common and very important topic in neurophysiology. Now let's see, when you talk about pathways which are coming from and going to the brain, they are involving many tracts. Okay, so there are two types of tracts, like ascending tracts or pathways, which are mostly sensory, and descending tracts or pathways, which are mostly motor. So ascending tracts or pathways, they will deliver information to the brain, and descending tracts or pathways, they will deliver information to the periphery. Today, we will deal with the first one, that is the sensory ascending pathways. So, as I told you a little while ago, ascending pathways are bundles of nerve fibers which are linking with higher centers of the brain. Okay, so they will carry information from the periphery to the central brain. When you are talking about ascending sensory pathways, they are organized in 3 neuronal chains. You should know what is this 3 neuronal chain. In this 3 neuronal chain, there are 3 types of neurons. Those are first order neuron, second order neuron, and third order neuron. All right? Okay. So now we will look at what is this first order neuron. In first order neuron, cell body is in the posterior root ganglion. Okay. Now you know when you take the spinal cord, you have the posterior root ganglion. Okay. So it is connecting to the spinal cord through a central process, and from the posterior root ganglion, it is connecting to the peripheral receptors through a peripheral process. So I have shown peripheral process and central process of the posterior, or some say it as dorsal root ganglion, clearly in this diagram. Okay. So that is the first order neuron. Most of the ascending pathways, their first order neuron lies in this posterior or dorsal root ganglion, which is outside the spinal cord. Is it clear? Okay. Then second order neuron of most of these ascending pathways, either they lie in the posterior gray column of the spinal cord. Okay. You know that in the central portion of your spinal cord, it is gray, that is gray matter, and the peripheral part is the white matter. So when you are looking at this picture, you will sometimes misunderstand that, because now it is shown here the peripheral color is gray and the central color is white, but it's not the real situation. In the real situation, your central core is usually that is the gray matter, and peripheral is the white matter. So remember that. So if you say second order neuron of the most of the ascending pathways, ascending sensory pathways, either cell body lies in the posterior gray column of the spinal cord, this central part, or else in the medulla oblongata. So there are 2 places. All right. So ascends and synapses. So then what will happen after synapsing? The second order neuron, the axons of them will ascend and synapses with the third order neuron, which is lying at the thalamus level. Okay. Right. So this is the third order neuron that is in the thalamus. Almost all the ascending sensory pathways, their cell bodies are located in the thalamus and gives rise to projection fibers to the cerebral cortex, post-central gyrus, which is the sensory area. Okay. So usually now you can understand that first order neuron is always it is in the posterior root ganglion. Second order neuron will be in the spinal cord level or else in the medulla oblongata, and third order neuron is in the thalamus. Okay. So with that basic overview, we will see what are the types of sensory ascending pathways. There are two types of pathways, sensory ascending pathways in our body. Okay, main 2 types I'm talking about. There are many other small indirect pathways are there, but the very commonly talked very important two types of pathways are, first one, dorsal column or medial lemniscal pathway, or some say it as dorsal column medial lemniscal pathway. Either is correct. And the second one is anterolateral spinothalamic pathway. Okay. First one is dorsal column or medial lemniscal pathway. Second one is anterolateral spinothalamic pathway. Okay. So when you talk about the dorsal column or medial lemniscal pathway, it is carrying fine touch, right? Vibration and joint position sense. While your anterolateral spinothalamic pathway will carry pain, temperature, and crude touch, tickle, itch, and sexual sensations. So now we will look at one by one in detail. First one is dorsal column medial lemniscal pathway or system. It has large myelinated nerve fibers. Usually they transmit signals very quickly, right? At velocities of 30 to 110 meters per second. And also in this pathway, it has a high degree of spatial orientation of the nerve fibers with respect to their origin. I will touch on it quickly. We'll see what is this spatial orientation means. And remember, is limited to discrete types of mechanoreceptive sensations. I told you it will carry fine touch, joint position sense, and vibration. All right. In contrast to the anterolateral spinothalamic pathway, which carries lots of sensations. Okay, that's why I say it is limited to discrete types of mechanoreceptive sensations. So these are the sensations. Again, I'm putting that is fine touch, vibration, and position. Position means usually joint position sense. Right. Now, are you ready to go a journey with me through this dorsal column medial lemniscal pathway? Okay, let's start. Okay. Now, sensory signal is carried by large myelinated fibers at a velocity of very fast velocity, 30 to 100 like, right? From the specialized mechanoreceptors, right? And they are now synapsing in the first order neuron that is in the dorsal root ganglion. Okay. And from the first order neuron, they are coming and entering to the spinal cord. Okay. Through the spinal dorsal root. You can see that. And then it divides almost immediately to form medial and lateral branch. Okay. Now it is coming through the dorsal root, right? First order neuron, that central process, it is coming through the dorsal root of the spinal cord. And there are two branches, medial branch and the lateral branch. Okay. So now when you talk about the medial branch, it turns medially first. Okay. It turns medially and upward. You can see that now in this red color, I have highlighted I have marked the medial branch. It is coming and turning upwards and going in the dorsal column, white column. Understood? And then proceeding by way of dorsal column pathway all the way to the brain in the same side of the spinal cord without changing its direction. Okay. Then what will happen to this lateral branch? This lateral branch enters the dorsal horn of the gray matter. It is not going to the white matter at the very beginning. In the, the very beginning, it is entering to the dorsal horn of the cord gray matter and divides many times to provide terminals that synapse with local neurons in the intermediate and anterior portions of the gray matter. So majority will enter the dorsal columns of the cord and travel upward again as with the medial branch. Many fibers are very short, right? They will form and they will terminate locally in the spinal cord gray matter, and they will be important to elicit spinal reflexes locally. And also some branches, others, they will give rise to spinocerebellar tracts. Okay. So there are here there are spinocerebellar. You can see dorsal spinocerebellar tract, ventral spinocerebellar tract. So there are so many other branches. So what is the course of lateral branch now? It will go and majority enter the dorsal columns of the spinal cord and travel upward to the brain with the medial branch. And many fibers will be terminating and doing the local spinal cord reflexes. And very few will give rise to spinocerebellar tracts. So there are three pathways of this lateral branch. Remember that. But the major, most important part is the medial branch, which will quickly ascend in the dorsal column of the spinal cord as its dorsal column pathway. Got it? Right. So now I told you, these are having a phenomenon called highly spatial, highly orientated. Spatial orientation is very high in this dorsal column medial lemniscal pathway. So what is this? That means now when you take your body, fibers which are coming, the receptors, right? The signals which are coming from the lower parts of the body, they are usually located and they are accumulated in this. Now, if you take the whole dorsal column like this, if you divide imaginally, right? Imaginally, if you divide it into two parts, columns, that is fasciculus gracilis, and this is medial part. Medial means towards your body, and towards out of the body, that is laterally. Out of the way, that is laterally. Okay. So fibers from the upper parts of the body, they lie in the fasciculus cuneatus. That is more laterally. Okay. If it is more centrally, that is called fasciculus gracilis. Can you understand? These are actually fiber nerve tracts which are located in the dorsal column. So fibers from lower parts of the body are highly orientated in the medial aspect of the spinal cord as fasciculus gracilis, while fibers from the upper parts of the body will be highly located, highly orientated in the lateral portion of the spinal cord dorsal column as fasciculus cuneatus. Understood? So this distinct pattern of the spatial orientation exists throughout the spinal cord up to the thalamus and also to the cerebral cortex as well. So that is why I told you this dorsal column medial lemniscal pathway is highly spatially orientated when you compare it with the other one. Right. Now, again, we'll come back to the pathway, the journey, right? So now we knew that there are two branches, medial branch and the lateral branch. Now, okay, medial branch will be going up, okay? And they are going in the dorsal columns. Now, you know, there are two sets of nerve fibers are there from the lower body. It is in more medially, that is fasciculus gracilis, and upper parts of the body, that is fasciculus cuneatus. Still, it is in the dorsal column. And these columns will pass uninterrupted, okay? That is why it is called dorsal column. Throughout, it is going in the dorsal column. And it is going uninterrupted up to the dorsal medulla. And there, they synapse in the dorsal column nuclei. There are two nuclei which are correspondent with the dorsal column, that fasciculus gracilis and fasciculus cuneatus. Like the nucleus is known as cuneate nucleus and gracile nucleus in the medulla oblongata. Okay. So cuneate nucleus and gracile nucleus, they are the spots where you have the second order neuron of the dorsal column pathway. So what is the dorsal column pathway? The second order neuron, that is the cuneate nucleus and the gracile nucleus of the medulla oblongata. So the fibers which are coming from the fasciculus gracilis will synapse in the gracile nucleus, while the signals which are coming through the fasciculus cuneatus will synapse in the cuneate nucleus of the medulla. So that is the second order neuron. After synapsing, now the fibers of the second order neuron, you can see they are synapsing like this. They will cross to the opposite side. They will cross at the level of the medulla, and again they are taking the same pathway. Okay. Cuneate pathway will take the cuneate pathway in the opposite side. Gracile pathway will take the gracile in the gracile nucleus, that along that pathway up to the brain cortex. in the same pathway, okay, in the opposite direction. So that is the place where only dorsal column pathway will cross to the opposite side. Remember that as well, after synapsing. And after that is the second order neuron, okay? Okay, so in the medulla, second order neurons decussate or crossing immediately to the opposite side and continue upward to the medial lemniscus. Now you call that band, neuronal band, as medial lemniscus. That is why we call this pathway as a dorsal column medial lemniscal pathway. Lemniscus means a band, like a ribbon, okay? Nerve band like. So in the thalamus, medial lemniscal fibers terminate in the thalamic sensory relay area, which is called ventrobasal complex. Okay, so that is the third order neuron. From the ventrobasal complex of thalamus, now with the synapse there, that is the third order neuron, they will project mainly to the post-central gyrus of the cerebral cortex, which is called the somatic sensory area 1. Somatosensory area 1. We will see what is this 1 and 2 of the somatosensory area. But for the time being, you just remember it is going and relay, or it's going and ending in the somatosensory cortical area 1. Okay, the first time. So now finish. Now we have done the dorsal column medial lemniscal pathway. It's easy. Okay, so you know it is coming and from the dorsal root ganglion is the first order neuron, and the signals are coming, okay, and they are coming upward, okay, entering from the dorsal horn of the spinal cord, and immediately after entering the spinal cord, it divides into two branches, medial and lateral. Lateral will divide into so many branches, while the medial branch will take the course up quickly in the same dorsal column, same side dorsal column of the spinal cord. And there are two pathways, fasciculus gracilis and fasciculus cuneatus, and they will go up and up and up until it reaches that is the first order neuron, still no synapses, and then going to the medulla oblongata. They have the cuneate nucleus and the gracile nucleus, and they will synapse, that is the second order neuron. Then immediately after this synapsing, they will quickly decussate to the opposite side and will travel along those lemniscal pathway, that is called the medial lemniscus, right? And going to the third order neuron, which is located in the thalamus, ventrobasal complex of the thalamus. From the thalamus, the signals from the third order neuron will go and end in the somatosensory area 1. Okay, so that is the dorsal column medial lemniscal pathway. Right, so up to the medulla, it is known as the dorsal column, and from the medulla, after decussating up to the thalamus, it is known as medial lemniscus. Right, so this is the summary. Now I have summarized. Okay, I told you, no, lemniscus is a ribbon, no band-like thing. So another important thing is it is a very quick one, 30 to 110 meters per second, and large myelinated nerve fibers are there. And very discrete amounts of sensations will be carried. Only 3, like 3 or 4 maybe. Crude, that is fine touch, vibration, and joint position sense. Okay, that's it. Then we will move on to the next one. That is anterolateral spinothalamic pathway. Okay, so in contrast to the dorsal column pathway, these are having smaller myelinated fibers. Therefore, their speed is also low, about a few meters per second up to 40 meters per second. And again, I'm telling, it has much less spatial orientation. Not like the dorsal column pathway, less spatial orientation is there. But it has an ability to transmit signals from broad spectrum of sensory modalities. Pain, warmth, right? Cold, that is collectively as temperature, and crude tactile sensation. Crude tactile means there is no much discrimination, okay? Not like the fine touch. This crude touch has no, just touch. We can't correctly say where is the touch, what is the position. That is the meaning of crude. No discrimination actually, okay? So here now let's start the journey of the anterolateral spinothalamic pathway as well. Now Are you ready? Okay. So sensory signals from the dorsal root ganglion, that is the first order neuron. Again, like the dorsal column pathway, it is entering to the spinal cord from the dorsal spinal nerve roots. So they synapse. Now here, there's a synapsing point. First order neuron is in the dorsal root ganglion. Immediately after entering to the spinal cord, they are entering to the dorsal gray horn, okay? Spinal gray matter. And in the gray matter, there is a collection of neurons known as substantia gelatinosa group. That is the second order neuron. Okay, now after entering in the gray horn, gray matter, there is substantia gelatinosa. Quickly, this will synapse. That is the second order neuron now. I will show you a cross-section histological slide here. Now you can see this is the gray matter now. This is the white matter. So substantia gelatinosa is here like this. Okay. So it is substantia gelatinosa in the gray horn of the spinal cord. Immediately after entering, it will synapse. So anterolateral fibers of second order neuron, then after synapsing, it is second order neuron. Then the fibers from the second order neuron will cross immediately in the anterior commissure in front of the central canal of the spinal cord to the opposite side of the spinal cord. And they will take anterior and lateral white columns. Okay. That means now they will, they will synapse, that is the second order neuron now, that is substantia gelatinosa, and then quickly they will go in front of, they will decussate in front of the central canal. You can see it is the white commissure, anterior white commissure in front of the central canal, this band-like thing. So it is going, and then what will happen? Either it will enter to the anterior white matter or else lateral white matter. If it takes the pathway of anterior white matter, that pathway is now will be called as anterior spinothalamic tract. If it takes the pathway of lateral white matter, it is known as lateral spinothalamic tract. Can you understand that? So I will show you that. Here, can you see? They turn upward toward the brain by the way of anterior spinothalamic tract, or else it will enter this lateral white column and upward, going upward as lateral spinothalamic tract. So that is why this one is from the beginning known as anterolateral spinothalamic pathway. Okay. Until it is synapsing and decussating, it will be as one. But after decussating and going in anterior white column or lateral white column only, they will be divided into two sub-pathways. Those are known as still they can be called as anterolateral spinothalamic pathway. But usually we call them as either anterior spinothalamic pathway or lateral spinothalamic pathway, because they will specifically carry specific sensations. Now, if you take anterior spinothalamic tract, that will carry crude touch only. Okay, it is not very frequently being talked about. But lateral spinothalamic tract, okay, it is carrying pain and temperature. Therefore, it's very, very important and very commonly being taught. Okay, right. So, is it clear? Right. Then what will happen? Tactile signals, this crude touch sensation, and a small fraction of pain signals will be now transmitted to the ventrobasal complex of the thalamus, that is the third order neuron, and from there to the somatosensory cortex, that is somatosensory area 1. Okay. Okay, so it's clear now. Now you know that is dorsal root ganglion is the first order neuron. Then it will enter to the gray horn of the spinal cord, and immediately after entering the gray horn, what will happen? It will synapse in the substantia gelatinosa, that is the second order neuron. After synapsing, the second order neuron fibers will cross or decussate to the opposite side in front of the canal in the anterior commissure of the spinal cord. If they travel along the white column, anterior white column, it is known as anterior spinothalamic tract, which will carry crude touch. Or else if they enter to the lateral white column, that is known as lateral spinothalamic tract, which will carry pain and temperature. And going up and up and up in the opposite direction, okay, and entering to the ventrobasal complex of the thalamus, that is the third order neuron. From there, third order neuronal fibers will go to the somatosensory area 1. Okay, they will carry pain, temperature, crude touch, and so many other sexual sensation, each tickle like that also. Okay, so that is the summary of the anterolateral spinothalamic pathway. So we have done. Okay, now this is summary actually. Now here there's a table here. You can, from your brains, you can fill what is the first order neuron, what is the second order neuron, third order neuron, and what is the pathway, and what is the destination. Okay, so as a homework, to try to do it on your own, and whether it is correct, you can check. Right. Now we'll touch on the cortical integration of the sensory perception as well. Now, if you talk about the somatosensory cortex, human cerebral cortex is divided into about 50 distinct areas by a person called Brodmann. Okay, Brodmann's area. They are designated as Brodmann's areas based on the histological structural differences. Okay, so now we will keep it aside for a little while, and we will talk about now what will happen to the sensory signals now. Sensory signals from all the modalities of sensations will terminate in the cerebral cortex, immediately posterior to the central fissure. So usually the anterior half of the parietal lobe, they will receive and interpret somatosensory, most of the basic somatosensory signals. But posterior half of the parietal lobe is usually doing very higher levels of interpretation. So for the time being, we are mainly talking about anterior half of the parietal lobe. Okay. So based on the distinct and separate spatial orientation of different parts of the body, these two somatosensory areas are identified. Okay. So they are located in the anterior parietal lobe. Somatosensory area 1, okay, and somatosensory area 2. Somatosensory area 1 is located in the anterior parietal lobe, and which is very, very extensive, and almost always that is having a higher degree of localization. So usually they have identified Brodmann area 1, 2, and 3 are located in this somatosensory area 1. Okay. Then if you talk about somatosensory area 2, that is again in the anterior parietal lobe, but poor localization is there. That is why I told you most of the third order neuron which are coming from the thalamus are going and lodging, or they are terminating in the somatosensory area 1. And after doing all the interpretations, only somatosensory area 1 will send the projections to other areas of the cortex. Then if wanted only, they will send signals to somatosensory area 2. And if other interpretations are needed from the hypothalamus, hippocampus, amygdala, they will send signals for few, to interpret more and more if they want. Otherwise, they can do it within the somatosensory area 1. Okay, right. So now here also you have to know that spatial orientation of signals in somatosensory area 1. Now, some areas of the body are represented by large areas in the somatic cortex. As an example, if you take your lips, right, which are greatest of all, followed by the face and thumb, they will be represented in a very large amount of area in the cerebral somatosensory area, cortical area, large area. Whereas the trunk and the lower part of the body will be represented, I talk about the sensations, relatively small areas of the cortex. So the sizes of these areas are directly proportional to the number of specialized sensory receptors. So each area contains a somatotopic map of the body. That is known as, this person is known as imaginary body homunculus, sensory homunculus. Now, as I told you, you can see lips, face, and these ears, right? They are mostly represented. And your hands, especially your thumbs, right? They are being mostly represented in your somatosensory area, cortical area, rather than this body and the lower extremities of the body. That is why this man is so small in his body and lower extremities compared to big lips, big ears and face, and also the hands. Okay? That is the meaning of a homunculus. Okay? So you can see here, big lips are here, big face, and thumb is very big, but your lower extremities are very, very small. Okay, hands and your body, those are very small. Genital areas, very small. Okay, so if to learn about the functions of somatic sensory cortex, they will localize discretely the different sensation in different parts of the body. That is clear. And also judge the critical degrees of pressure against the body. Okay. Weights of the body can be judged. Shapes and form of the object, that is known as a phenomenon known as stereognosis, that is a higher sensation. And judge texture of materials, or like whether it is soft or very rough ones. And if you have damage to the sensory cortex, it will result in decreased sensory threshold, and you can't discriminate, right? The properties of tactile stimuli and inability to identify objects by touch, that is known as astereognosis. Okay, right. Now, I think we have done 90%, okay, most of the parts of these ascending pathways, and we have learned some features about your somatosensory cortex as well. Now we'll deal with few things of this sensory pathways. If somebody says what is perception, few terms which are commonly being used in your textbooks. Perception means the process by which the brain organizes and interprets the sensory information. So perception is very important. Not only ascending and detecting all the modalities of sensation, perception is very, very important. Okay. And then what are dermatomes? This is also a different topic, but very related to the pathways, sensory pathways, because each spinal nerve innervates a segmental field of the skin. That is called a dermatome. So when you are talking about the pathways, you have to, ascending pathways, you have to know, you have to have an idea about the dermatomes as well. Okay. Right. So few sensory abnormalities, clinically important ones like anesthesia. What is anesthesia? Means absence of sensation. Paresthesia means pins and needles. That is numbness. You can feel, but it is numb. It is pins and needle sensation. Then hemianesthesia. Half of your body you have loss of sensation. Then when you're talking about the clinical cases relevant to this sensory abnormalities, usually you come across these two terms, ipsilateral and contralateral. Contralateral means other side, right? And ipsilateral means same side of the body. Okay. Right, we will go through 3 case studies very quickly and try to locate some disorders. The first case study is on Mr. Pereira, 45-year-old patient, who is complaining of loss of touch and vibration sensation on the left lower limb with loss of pain sensation on the right lower limb, right? So what is this neurological lesion? Now here you can see loss of pain sensation in one side and loss of touch and vibration in the other side. Okay, so what is it? This is due to hemisectional damage of the spinal cord. Okay, hemisection is being damaged. Therefore, what will happen? It is a penetrating tumor or trauma that is usually due to a thing called Brown-Séquard syndrome. Okay, so loss of pain, temperature, and light touch of the opposite side will be there, while because it is crossing to the opposite side, no, but same side, they are having the, dorsal column pathway functions will be affected. Loss of motor function and vibration, precision, deep touch sensation of the same side of the cord will be gone, while loss of pain, temperature, and touch, right? That is crude touch sensations which are coming from the opposite side will be affected. So that is known as Brown-Séquard syndrome. Then the next one, 50-year-old female patient complains of loss of pain and temperature sensations in both hands for past 6 months duration. On examination, there were burn marks on her fingers and palms of the hands. Touch, vibration, and joint position sensors were intact. So this is a condition known as Syringomyelia. Okay. That is due to destruction or degeneration of gray and white matter, which is adjacent to the central canal of the cervical spinal cord, which is leads to cavitation and accumulation of fluid within the spinal cord. Okay. So here actually, because in the anterior commissure of the spinal cord, you are having the decussating fibers of the anterolateral pathway, they will go in front of the central canal. So if you have a problem or destruction or degenerative lesion in the central canal of the spinal cord, when it is expanding, definitely the first and foremost sensations which are being affected is the decussating fibers of the anterolateral spinothalamic pathway. Okay. So there, of course, again, you are affecting the pain and temperature pathways. Okay. So that is why you have pain and temperature sensations are being affected first. But with the time, if it is going and expanding to the posterior or the dorsal column, then there are touch, pressure, and touch and proprioception, vibration also can be affected. But at the very beginning, their pain and temperature pathways are being affected. Okay. So that is Syringomyelia. I'm just going through these case scenarios because I want to show that the things you have learned today, right, the physiological aspects are very much relevant to your clinical cases. Okay. Right. So this is the one I have told you. And the next one is another patient, 55-year-old patient, complains of numbness of both hands and feet for a few weeks. He's on treatment for diabetes for 10 years. Okay. So this type of disorder, sensory deficit, is known as glove and stocking type hyposthesia. That means sometimes numbness or not anesthesia, hyposthesia. That means the feeling of the sensation is reduced, not normal. Okay. So this is glove and stocking type. Usually glove and stocking type sensations are being seen in diabetic patients. Diabetic neuropathy is the cause for this type of a sensation. Okay. Right. So you can see how diabetic foot disease, which is a result of actually diabetic neuropathy, how it is painless. He can't, now he's having hyperesthesia first, but then it can go to anesthesia, like type of sensory loss. Then, of course, he can't feel the pain, right? So even needles, they can be put without anesthesia from outside. They can't feel anything can be put, right? Through and through needles can be sent. So that is the thing, very, very worried scenario or a complication of diabetes mellitus. Okay, so we have to have drugs, and you have to be very tight on tight control of drug, food and glycemic control also to prevent all these complications. Okay. Right. So this is from actually a very famous medical book of your medical students. So this is very important. Now there are different types of sensory lesions are here. Maybe not related to the today's topic, but related to all the sensory lesions, sensory pathways. So you have to know that according to the type of the lesion, you can locate where is the lesion is, depending on the clinical features. Okay. Right. With that, I hope that you have learned a very brief overview of the sensory ascending pathways. You have a thorough knowledge now on anterolateral spinothalamic pathway as well as the medial lemniscal pathway, dorsal column medial lemniscal pathway. And we went through a few clinical scenarios as well, which are relevant to today's topic. Few terms, new terms we learned as well. So I hope that you have learned something from today's lecture. So hope to see you soon from another new lecture. Till then, goodbye to all of you. Have a good day.